launch into the cardiovascular system. Some of this, certainly I've imagined the first third of it should be a recap, so I'm going to go through it pretty quickly. Okay? And then we will take a break and start into the respiratory system. Okay? We may or may not get through the whole of the respiratory system. We probably won't, but that's fine. It's okay. We'll finish that up on Wednesday. Okay, so let's start up. Like I say, this should be a recap for all of you. Okay, from your physiology classes, from your anatomy classes, in terms of certainly the anatomy of the heart. Of course, just very quickly, if we trace the pathway of a red blood cell through the heart, we started at, say, the right atrium. Okay, we know it goes obviously into the right ventricle, and the valve that it flows over is the tricuspid valve. Why? It's called tricuspid. It's got 3 valve leaflets. Okay. From there, it's pumped into, as you know, the right and left pulmonary arteries that go to the lungs, and the valve that controls that is the pulmonary valve that goes to the lungs. The gas exchange, which we're going to talk about, comes back via the left pulmonary veins into the left atrium. There's a slight contraction. Blood moves into the left ventricle over the mitral valve. Okay, and then it's pumped, as you know, into the aorta. Okay, and we have the aortic valve that separates the two. Okay. I'm going to use the term mitral valve. I probably will use the term the tricuspid valve. They're also known as the, what else are they known as? What's that? Bicuspid. Or the left AV valve. Also, some textbooks use the AV valve, atrial ventricular valve, left and right. Okay, but I'll use the term mitral valve. I'll use the term tricuspid valve, as your book does. I'll use the term aortic valve and the pulmonary valve. Okay, so that's quick anatomy of the heart, which you should all know. In terms of the systemic and pulmonary circuits, we'll talk about the pulmonary circuit in particular in the next lecture. Okay, we're going to concentrate more on the systemic circuit in this lecture here. In terms of the systemic circuit, it's got a very, very high resistance. Okay. So resistance to flow is 5 to 7 times greater in the systemic circuit than in the pulmonary circuit. Why? Why do you think that is? So the resistance in the systemic circuit here is a lot higher, obviously, than the pulmonary circuit.
It's oxygen rich.
It's oxygen rich, which means it's going out to all the tissue beds, the organs, okay, so there's a lot of resistance to flow. Okay? A lot of resistance to flow. Whereas in the pulmonary circuit, it's only going up to the lungs. Okay? So because of that, then, arterial blood pressure is 5 to 7 times higher than the pulmonary circuit. So arterial blood pressure, which is in the systemic circuit, is also 5 to 7 times higher than the pulmonary circuit because the resistance to flow is a lot higher. Okay. In terms of the myocardium, the thickness does vary. So the myocardium is the cardiac muscle. Okay. That thickness does vary according to the stress placed on the chamber wall. And in particular, left ventricle can change in terms of thickness. So it's the most powerful of the chambers and the largest chamber. And certainly with endurance training and resistance training, the size of the left ventricle can increase. We call that left ventricular hypertrophy, or LVH. Okay? Left ventricular hypertrophy. It can change with endurance and resistance training. It gets bigger. Okay? Intercalated discs in the myocardium, what you like the cardiac muscle, allow impulses to travel quickly and to allow it to act as one large muscle fiber. In other words, all fibers in the heart contract together as one unit. So how do you think that works? What's an intercalated disc? In physiology, we actually call it we have another term we call intercalated discs. You've heard the term a gap junction? So what's a gap junction? What's the role of a gap junction? What's that? Conduct the impulses. You just read that right off the slide, see? Okay, so lots of cardiac muscle cells, right? You can't have these individually contracted. You have an uncoordinated contraction, the part will go into an arrhythmia, tachycardia, death. Okay? So the chambers have to contract as one. Okay? To contract as one. So these are cardiac cells. Between each cardiac cell is a gap junction. So it's a pathway of low resistance. So resistances, or the action potentials, can move from one cell to another very, very quickly. So the pathway for least resistance. That's what we call intercalated distal gap junctions. Okay? Completely different to skeletal muscle, right? Skeletal muscle is not set up like that. So that's one difference between skeletal muscle and cardiac muscle. Okay? It's very important that that muscle contracts as one. Those chambers contract as one. Mechanism of cardiac muscle contraction. Basically, this is a diagram out of your book. I don't want to spend a lot of time on it. It's kind of similar to skeletal muscle, where you have the here's a T-tubular, for instance, right? You know what the T-tubular does. Action potential comes down the T-tubular. We have the cytoplasmic reticulum, where calcium is pumped into, and also calcium is released from to bind to troponin, as you know. Not much different from cardiac muscle. And between the T-tubule and the cytoplasmic reticulum, there is a receptor, DHPR receptor. Okay, and as you know, it's like a skeletal muscle that's opened up, triggered by the action potential coming down. Okay, and that is intimately bound to a ryanodin receptor here located in the cytoplasmic reticulum, and upon that voltage change, it releases calcium. Okay, we spoke about it briefly when we talked about skeletal muscle. I'm going to let you read that. The difference between skeletal muscle and cardiac muscle. We've already spoken about one difference over here. Okay. In terms of the coronary circulation, of course, the heart is a muscle, right? So it has its own blood circulation, veins and arteries. Okay? One of the famous ones that you'll hear is the left anterior descending artery, LAD, okay, right here. Left anterior descending artery. The reason you hear about this a lot in terms of pathology, that's the one that tends to get blocked a lot. In heart disease, we get fatty deposits, atherosclerosis. So this artery here tends to get blocked a lot. Okay, left anterior descending. And along with the circumflex here, it's actually, as you know, heart is pumped from the left ventricle into the aorta, and immediately, right after the aortic valve, we have the left anterior descending coming out and the circumflex. So the heart is the first organ to receive blood before any other organ. Okay? It's a highly metabolic tissue. Okay? So, we have arteries, of course, and we have veins. Okay? Okay, cardiac conduction system. Again, this should be a recap for all of you. We're going to talk about the SA node, the sinoatrial node, the atrial ventricular node, the AV bundle, the bundle of hairs, and the Purkinje fibers. How does the heart beat? And that's what we're going to talk about quickly, since you've done it before. Okay. Okay, so we talk about the right atrium. We're going to talk about two nodes, the SA node and the AV node. Sinoatrial node. What's the purpose of the SA node located in the right atrium?
Initiate the impulse.
Right, so it triggers or issues the action potential. Okay? Okay. And of course the pulse is not just one action potential, it's a whole bunch of action potentials. This is a cell, we call it the pacemaker cell of the heart, right? If you remember? SA node, pacemaker cell. And the action potentials, the electricity spreads throughout the right atrium and is eventually picked up by the AV node, the atrial ventricular node. So what's the purpose of the AV node? It does. It does it by holding onto the signal for like a millisecond. Okay, it delays it. It holds it, and then it shoots down. Okay, the bundle of hairs, or the AV bundle. Okay, down the bundle branches, the left and right bundle branches. And then eventually spreads over the myocardium, left and right ventricles. That's the Purkinje fibers. That's where it ends, right? And it's set up that way, right? Because, as you know, the mechanical events of the heart follow the electrical events, such that as these action potentials are generating down the AV bundle and the Purkinje fibers, which would then go down here and then come back up toward the base. Which way are we contracting? We're contracting and squeezing in that direction, right? So the reason the Purkinje fibers are coming up, because that's the way the blood's going to be pumped. Okay? So contraction is occurring, squeezing from the bottom to the top, right? Okay. So that's the intrinsic control. If the SA node becomes damaged, for some unknown reason, it does, as you know, the AV node can take over the pacemaker cell properties of the heart. What also can happen is if both of those are damaged, any other cardiac cell can also take up those properties. If we have that occurring, we have trouble. Because then we get uncoordinated contraction, because it could be that one of the cardiac cells down in, let's say, the left ventricle comes to pacemaker cell of the heart, and you can see you're going to run into problems there. And that's where they actually have to stop the heart and start again, or stick in a pacemaker into the right atrium, or the outside of the heart. Okay. So that's the intrinsic control. Extrinsic control is by the sympathetic nervous system and the parasympathetic nervous system. So the autonomic nervous system is controlling, if you like, the extrinsic. Okay? So the parasympathetics acts through the vagus nerve, releases acetylcholine, ACH. What does it do? Decreases heart rate and forces cardiac contraction. So we get a hyperpolarization, if you like, you know about this, right, of the conduction cells. If there's an absence of vagal tone, the heart rate is set around about 100 beats a minute, which means that that pacemaker cell is sending out impulses about 100 beats per minute. If we so that's what it means by in the absence of vagal tone. With maximal vagal tone, that heart rate can come right down to 20 to 30 beats per minute. Conversely, the sympathetics, that increases the rate of impulse generation and conduction speed. So therefore it's going to increase heart rate and force of contraction. We go as much as 250 beats per minute in some cases, or Okay? Now, so, what the book doesn't show is very crude heart, right? 4 chambers. SA node, AV node, that's the right atrium. Okay? We have these autonomic nervous system fibers coming in. Okay, so we've got parasympathetics, sympathetics, synapsing onto the SA node and the AV node, right? That's what we mean by extrinsic control. Where they're coming from the spinal cord, right? So we've got parasympathetic, sympathetic nerve fibers synapsing with the SA and AV node, controlling heart rate. Okay, as you know, with the parasympathetics we're releasing ACH, with the sympathetics we're releasing norepinephrine. Okay? Epinephrine and norepinephrine releasing the adrenal medulla. We know there's also that's coming from the adrenal medulla, right? So these are neurotransmitters, right? These are neurotransmitters. Acetylcholine and norepinephrine are neurotransmitters. Epinephrine and norepinephrine from the adrenal medulla, adrenal glands, right? That goes out, they go out into blood. So epi and norepi, more acting like hormones, they're going into blood, okay? And they are going to increase the force of contraction of those cardiac cells, okay, located in the ventricles only. That's the left ventricle, that's the right ventricle. So epinephrine and norepinephrine released into blood from the adrenal medulla has no bearing on changing heart rate. What they do, release in the blood, bind the cardiac cells, increase the force of contraction of the heart in the left and right ventricles. Okay. Because this was taken in thought, this is actually wrong. It doesn't increase the heart rate, okay? It increases the force of contraction. Okay? Scrub that. Another slide we look here, just talking about the relative contribution of the parasympathetic and the sympathetic. Quite obviously, it's what we got here is fractional oxygen uptake, obviously 0, the rest at 100%. It's your heart rate, because as you can imagine, as you're increasing exercise intensity, the sympathetics are going to predominate, right? We know that. Let's just talk about the shift. Okay, heart rate and endurance training. In terms of resting heart rates in adults, in general, anywhere between 60 to 85, even 100 beats per minute seems to be about normal, okay? With endurance athletes, particularly elite endurance athletes, they can get their resting heart rates down to 35 beats per minute. Just sitting there like you are at the moment, okay? Due to probably very, very much increased parasympathetic stimulation. Okay. Pathological bradycardia, so endurance, so that's with endurance training. With pathological bradycardia is a heart rate less than 60 beats per minute. Okay? That's a problem. Now, I'm an endurance athlete, and I still am. I've been doing it for about 20 years, and I always have problems when I go into a doctor's office or a dental office now, right? Because they always take your heart rate and your blood pressure, right? They have to do that. So I go in and my heart rate can be down to 37, 38 beats per minute, 40 or even 40, 45, depending if I just walked in, okay? and they start getting all flustered because my heart rate is so low. And I have to say, no, it's not pathological bradycardia. I'm fine. It's just that I'm an athlete and I'm an endurance athlete, and I have heart rates down like this. But it's every time I go in, they get all flustered because they have to be very much aware. For anyone who walks off the street, if their heart rate is less than 60 beats per minute, they have to flag it up. Okay? Okay, ECG, electrocardiogram. You're going to do a lab. I don't think you've done it yet. Have you? ECG lab? No. You're going to do a lab involved around electrocardiograms. Okay? And what is it? Well, if you like, it provides a graphical record of the electrical activity of the heart, and certainly can be used to aid clinical diagnosis of heart disease. Okay? We can obviously look at resting tracings and also exercise tracings as well, which is very common with a cardiologist, right? Put you on a treadmill, put you up to a 12-lead ECG, and look at the tracing. Okay? This is obviously a very simplified schematic of a very nice tracing here, but it's not true, it's not a real tracing, of course, of an ECG. We'll go through it very quickly. You've probably seen something like this before, where this is obviously a resting ECG. We have what we call a P wave, there's a blip here. We have a big spike, QRS complex, then we have a T wave. Okay? That's one big. There's your second. Okay? We can discern a lot of information from this ECG. We can look at the sizes of how tall the waves are, the shape of the waves. Sometimes in pathology the P wave can be flipped. Goes down like this, as with the T wave, it can be flipped, which is not a good thing. The QRS complex, we can look at gain or height of the R wave. We can look at the width of the R wave, because there's norms, right? The width of a normal R wave would be about 0.12 seconds. If it's wider than that, it would tell the cardiologist there's a problem. Sometimes we see the absence of an R wave, sometimes it's flipped. And it's wide. That could be a problem. So we can see things like, we can see something like a normal P wave, and then something like this. There's your T wave, there's your P, kind of, if you like, that's your R wave, but it's being flipped. If it's being flipped, that's what we call a left bundle branch block. If you go back to that, if you go back to the heart, and you have those two bundle branches coming down, right? It means the left bundle branch is blocked, and that's very common in heart disease. And they have to go in and clear it, or they have to go and reroute the electrical conduction system around that bundle branch, or around that. So, because this is to do with the fact that there's dead tissue, so that the wave has to go around the tissue, dead tissue. So we can also, we can look at height, we can look at shape, we can also look at the length, if you like, of the segments, or the intervals, or between R and R. So we can get a tremendous amount of information out from that. Here's a real ECG taken on me back when I was a graduate student, I think, late 90s, no, 15 years ago actually. But this is a real ECG. As you can see there's the P wave, there's the QRS complex, and there's the T wave. There's the next thing, okay? And we've got different leads that we can look at as well. This is a 12-lead ECG. Obviously, we've got voltage in the y-axis, okay, voltage. And then we've got time in the x-axis. That's your intervals. Now, we have a very tall R wave. That's indicative of left ventricular hypertrophy. you've got a bigger voltage. If you've got a bigger voltage, you've got more cardiac muscle. So if you've got lots of, your myocardium, the left ventricular myocardium is very thick, the ECG will pick that up, and you'll have a very, very big R-wave spike. Okay? So it's very, very easy. If you bring an endurance athlete in, stick them up to an ECG, immediately, certainly first thing I would notice would be quite most likely a big, big R wave. Okay? So there's a guy here just about to or finish the ECG test on the treadmill. He's set up with a 12-lead ECG. He'll do a 3-lead ECG. Okay? Here's an example of an atrioventricular block ECG tracing. This is probably done during exercise. Here's the QRS complex. Here's the T wave. There's a P. And then there should be another QRS complex, right? But it's absent. There's a P wave, a P wave, a P wave. And then we've got a kind of QRS complex, another QRS complex. And then more gobbledygook and another QRS complex. We have all sorts of blocks going on here. So it means there's some sort of blockage between the atrium and the ventricle. Okay? Okay, so those are the key points. I'll let you read those through at time. In terms of cardiac arrhythmias, we've already mentioned bradycardia, resting heart rate below 60, tachycardia, resting heart rate above 100 at rest. Okay, obviously. With cardiologists, if you have problems, you can pick up things like premature ventricular contractions, you just skip the extra beats of impulse originating outside the SA node. Ventricular tachycardia, 3 or more consecutive PVCs. Ventricular fibrillation, contraction of the ventricular tissue is uncoordinated and can result in cardiac death. This is an example of ventricular fibrillation. Complete and utter mess. Complete uncoordinated contraction. Okay, where's the P wave? It's not, we can't see the P wave. The QRS, there's nothing there that we can discern that's normal about that ECG tracing. Okay? In that case, we'll have to stop the heart and shock it. Okay. Okay, cardiac cycle. Let's get into the cardiac cycle. So the cardiac cycle, right? Really, we're talking about from R wave to R wave. Okay. So it's defined as a mechanical and electrical events that occur during one beat. Systole to systole. We all know what systolic is and diastolic is, right? This diastole is the relaxation phase during of the heart, when we have the blood entering, or if you like, the filling phase of the heart, blood entering the ventricles. Okay? Like chambers filled with blood, and the systole is the contraction phase. Okay? The chambers actually expel the blood. So, probably seen this diagram before in physiology, the Wiggers diagram. This is straight out of your textbook as well. Okay, it looks complicated, it's not. Okay, it really isn't. We're going to look at let's look at I'm trying to think of probably the easiest one in terms of pressures. Let's look at the ventricular pressure, left ventricular pressure. This guy here, the guy who kind of knows-ish. This guy. We're going to trace this through. So we've got here, we've got a graph here of pressure in millimeters of mercury. Then we've got volume. Okay, this one here. Then we've got the ECG that corresponds to these events. And then we've got the phonocardiogram with the heart sounds. Okay. So let's kick off right here. The left ventricle, we're talking about the left ventricle only. Let's say, well, it could be the right ventricle as well, but the right ventricle would have decreased pressures. So let's assume we're talking about the left ventricle only. Okay? We've got the filling phase of the heart, okay, and the mitral valve. So we're filling from the left atrium into the left ventricle. But obviously the mitral valve is open, isn't it? And that's what's occurring. So pressure's going up slightly, the volume is going up. Now, the heart is a pump. There's 4 chambers. The heart works by changes in volume and pressure only. That's it. It's really quite simple. Pressure changes and volume changes. 4 chambers. Okay? 4 tubes coming off. Okay? So, when the pressure in the left ventricle is greater than the pressure in the left atria, we've got more volume of blood, that valve is going to shut. So it's a pressure change because the volume, we've got more volume of blood, and the pressure is greater than the left ventricle and the left atrium, it's going to shut that mitral valve. Okay? And that's what we've got going on here. Mitral valve closes. Now, we'll just talk about the left side of the heart to make it easier at the moment. Okay? We've got also the aortic valve, right, coming off the left ventricle into obviously into the aorta here. Okay? So, for a small amount of time, the mitral valve is shut and the aortic valve is shut. And that's where we get a big change in pressure. We get a big increase in pressure. Okay? That's known as the isovolumetric contraction phase from here to here. As you can see, there's a big increase in pressure. The reason it's called isovolumetric, iso means no change. There's no change in volume. Both valves are shut. Okay? Both valves are shut. There's a big rise in pressure. And eventually, of course, pressure in the left ventricle is going to be greater than the pressure in the aorta. And that aortic valve is going to open up. That's what happens. If the aortic valve opens up, what's going to happen is you're going to expel blood, right? There you go. You've got the ejection phase of the heart. So if you've got the ejection phase of the heart, then the volume in the left ventricle is going to go down. Also, right here, the aortic valve opens, we've got contraction, that's the QRS complex. Right? And one thing, if you go back to the mitral valve, when that mitral valve closes, that's the first heart sound. We'll pick that up. So we've got the ejection phase, and eventually what's going to happen is pressure in the aorta is going to be greater than the pressure in the left ventricle. The aortic valve is going to close. Right? That's our second heart sound. And we're going to get a big change, we're going to get a big drop in pressure while the aortic valve is closed and the mitral valve is closed. This is for a small point in time. So this is known as the isovolumetric relaxation phase. No change in volume, drop in pressure. Okay? Then the mitral valve opens. The mitral valve opens because pressure in the left atrium now is greater than the pressure in the left ventricle. There's not much blood left in the left ventricle, right? So that pressure is greater than that pressure. Mitral valve opens, and we're starting the filling phase of the heart again. Volume starting to increase. Okay? So, you can trace this through to anything you want. You can look at aortic pressures, you can look at atrial pressures, you can look, we've already looked at the ventricular pressure. It just needs time on your part to just kind of figure out what's going on. At first glance, if you haven't seen this before, it looks tricky. It's not. It makes a lot of sense. If you just think about the anatomy of a heart and what is occurring, okay, it's not that hard. It really isn't. Okay. But study that because you will see that again. I can guarantee it on the exam. Okay, so make sure that you understand the Wiggers diagram. Okay. Okay. Stroke volume and cardiac output. Again, you would have seen hopefully these terms before. What is stroke volume? Basically, it's the volume of blood pumped per contraction. So usually milliliters per beat. Okay? All right. Stroke volume is made up of the end diastolic volume and the end systolic volume. So stroke volume equals the end diastolic volume, we're defining in a minute, minus the end systolic volume. What's the end diastolic volume? Well, diastolic is the end of the end of the relaxation phase in the heart. So it's the volume of blood in the ventricle just prior to contraction, not afterwards. So your ventricle is completely filled with blood. That is your end diastolic volume. Okay? Diastolic kind of gives it away. It's the end of relaxation but prior to contraction. Okay? End systolic volume, ESV, is the volume of blood in the ventricle just after contraction. So how much is actually left in the ventricle after contraction? You never ever expel 100% of your blood from the ventricle. There's always a certain amount left, even at maximum exercise. Okay? So whatever's left is your end systolic volume. So obviously stroke volume equals EDV, end diastolic volume, minus ESV. Okay? In terms of cardiac output, that's the total volume of blood pumped by the ventricle per minute, usually expressed as liters per minute. And the equation to note that is cardiac output equals heart rate times stroke volume. Okay? So, you can also rewrite that equation, can't you? Cardiac output equals heart rate times stroke volume. And cardiac output equals heart rate times EDV minus ESV, right? And you just expand it out. Know these equations, they're important. Okay? So stroke volume equals EDV minus ESV, cardiac output equals heart rate times stroke volume, or EDV minus ESV. Okay. Ejection fraction then is the proportion of blood pumped out of the left ventricle with each beat. I've already said that you never pump out 100%. It is expressed as stroke volume divided by the EDV, that averages about 60% at rest. Okay? Okay. Now I want to talk about some of the factors that affect myocardial performance, the performance of the heart. And these are important to consider. Okay? Why? Because, well, if you talk about control of cardiac output, that's really what we're talking about, right? Control of cardiac output. We can go from 5 liters per minute at rest to up to 25 liters per minute in recreational athletes and up to 40 liters per minute in some elite athletes. So if you're talking about an elite athlete, that's 35 litre per minute change. Think about that. It's tremendous. And that cardiac output is controlled by 4 factors. We'll talk about them. Heart rate, afterload, preload, contractility. Heart rate is easy to talk about. We've spoken about it already. Heart rate, we all know that it's basically in this equation here, cardiac output equals heart rate times stroke volume. So if you increase heart rate, you're going to increase stroke volume. If you decrease heart rate, you're going to decrease stroke volume. Okay? We all already know that the autonomic nervous system, we spoke about it, right? The sympathetics and parasympathetics affects the pacing itself. Okay? Afterload. You may or may not have heard that term before. This is the pressure or force which must be overcome by the ventricles to eject blood into the pulmonary artery or aorta. So what I mean by that is it's the resistance downstream. So if you remember crude heart again, right? That ventricle, what's coming off the left ventricle is the aorta, right? That eventually becomes arteries. Okay? So these are the aorta and the arteries and the arterioles. That's your resistance. Okay? So the pressure downstream in the left ventricle, which increases because of all these tissue beds and the arteries and the arterioles, that's the pressure that must be overcome to eject the blood out. So if you increase the pressure downstream because of resistance, then you're going to increase the afterload. The heart has to work harder. So if you have a blockage or you have some atherosclerosis, narrowing of the arteries, for instance, some sort of pathology, okay, that increases the resistance, you're going to increase the pressure downstream, the heart's going to have to work harder, that's going to be a problem, and we say that you increase the afterload. Okay? That's what I've got written there, high blood pressure. So if you have high blood pressure, that will increase the afterload. Okay? Afterload is talking about the heart. Okay? So therefore then, if you increase the afterload, okay, because you've got high blood pressure, then you're going to decrease cardiac output, right? How much blood you can expel, and therefore you're going to decrease stroke volume because of that as well. They'll go hand in hand. Make sense? You're not going to expel as much blood. Preload, this is the initial stretch on the ventricular muscle wall prior to contraction. In other words, the end diastolic volume. So you completely filled up your ventricles, your left ventricle, let's say, the left ventricle, okay? And we term that preload. Okay, the initial stretch on the ventricular muscle wall, okay? Okay, that's your preload. The greater the stretch, so the more blood you can get in there, the greater the stretch, the greater the preload. Preload meaning prior to contraction, right? Within limits. So as end diastolic volume increases, we get more blood in here, end diastolic volume increases, then you're going to get more blood, right? So you're going to increase stroke volume. More stretch, more force of contraction. Okay? And we're going to talk about the Frankenstein law of the heart in a second, which talks about this relationship. Contractility is the fourth one, increase in force of contraction of the heart, this is independent of preload and afterload. It is purely due to sympathetic nervous system innervation. It has nothing to do with preload and afterload. We'll talk about that in a minute. Okay, now I want to get to the marvelous pressure volume loops. Okay, this is another way of looking at the cardiac cycle, like the Wiggers diagram, and it's simpler. Pay attention because you'll see these again on the exam. Okay, pressure volume loops. So what we've got here is a tracing of left ventricular pressure, like we saw before with the Wiggers diagram, with the mercury, and left ventricular volume, milliliters. Okay? So if we start, let's start here at A. I'll put the heart here again so you can follow through, just like with the Wiggers diagram. Let's say we've got 50 milliliters here, okay, left ventricular volume. Let's say the mitral valve opens. The mitral valve is opening, then we're filling the heart, right? The mitral valve is opening. Heart is running, blood is filling into the left ventricle. And we're obviously increasing our volume up to 120 milliliters. Okay? Then the mitral valve closes, reasons that we mentioned before about the pressure changes. And then we've got the isovolumetric contraction phase. Remember, there's no change in volume, but a big increase in pressure. Both valves are shut. The aortic valve and the mitral valve. Right here, so we go from C to D. Okay? Then the aortic valve opens, and we've got ejection. So what this means, we're going to finally end up with F, where the aortic valve closes, ejected most of our blood, the aortic valve closes, okay? And then we've got a drop in pressure but no change in volume, and that's called the isovolumetric relaxation phase, and then we're back to A again. And that's 1B. That's the cardiac cycle. And it's known as a pressure volume loop. Okay. Now then, here's our pressure volume loop again. And we're going to see how it changes in response to afterload, preload, and contractility. And these are all, these again, when you exercise, you're going to change your afterload, you're going to change your preload, you're going to change your contractility, right? So, let's look at preload first. Maybe that's the easiest to think about. So here's our control curve, right? Let's take the blue, this one here, as our control. Now, if you go back to this guy, that is your end diastolic volume right here, isn't it? The amount of blood left in the heart prior to contraction. That's your end diastolic volume or your preload. You agree? Okay, we haven't expelled any blood. That's the amount of blood that's in the left ventricle prior to contraction. Now then, if we increase the preload, or end diastolic volume, if we get more blood in, okay, what's going to happen? We're going to go from C prime, which is the control, to C. We're not going to change this curve anywhere else, only there. Okay? So if you go from C prime to C, then quite obviously your stroke volume is increased, because if you remember, stroke volume is end diastolic volume minus end systolic volume. So again, we go back to this curve here. Oops, not that one. Here's our EDV, end diastolic volume, like I just said, preload. And here, if you follow through from the ejection phase, right? We've gone in this direction. When the aortic valve closes, whatever blood is left in the heart, which is, in this case is 50 milliliters, that's our ESV, that's our end systolic volume. So we've got end diastolic volume, end systolic volume. Stroke volume is just a function of 2, isn't it? It's EDV minus ESV, so they have to switch from here to here. So if you increase preload, you end up with a curve like this, you're going to increase stroke volume. That would make sense. And that's what happens here. Okay? What about afterload? Afterload is increasing the pressure downstream. It means the heart has to work harder to pump blood. Okay? So if you increase the afterload, you're not doing anything here with changes in volume. You're changing pressures. The way to remember this, I remember when I was a student, right, is preload, or you increase preload or decrease preload, it's all to do with changes in volume only. If you increase or decrease afterload, it's all to do with decreases or increases in pressure. And they're independent of each other. So if you go from D prime, control afterload, to D, so you increase the afterload, it means the heart has to work harder to eject that blood. It means that heart is not going to be able to expel as much blood out, right? Which means you're going to follow a curve something like the brown one. And it means that you're going to end up with an end systolic volume that's higher, because you can't expel as much blood out, so you're going to be left with more blood in the heart, in the left ventricle. Does that make sense? Because you can't expel it. You can't expel as much as you could before. Therefore, your ESV has gone down. Your end systolic volume has gone down, which means your stroke volume has gone down. Okay? So that's an increase in afterload. Remember, a decrease in afterload, you decrease the afterload, you're going to increase the stroke volume. If you decrease preload, you're going to decrease stroke volume. And the last one I want to talk about is contractility. In this case, an increase in contractility. Contractility, remember, is independent of preload changes and afterload changes. So there's no change in preload, no change in afterload. All you've done is increase the sympathetic nervous system activity to the heart, particularly the ventricle, the left ventricle in this case. And if you increase the contractility of the heart, you can increase the force of contraction, you can expel more blood. If you expel more blood, then your ESV is going to go down because you're going to be left with less blood in the heart. Does that make sense? Okay? So you're going to follow a curve, something like this. You've got a more forceful contraction, so your end systolic volume, the amount of blood in your left ventricle after contraction has gone down. We've got a more forceful contraction, which means that if you increase the contractility, you increase the stroke volume. If you decrease the contractility, you decrease the stroke volume. Again, on first glance, like the Wiggers diagram, you might think these are really complicated. They're not. You need to work through them. They're very simple. They're intuitive, for me anyway. Okay? So again, it's all to do with pressure and volume changes. Okay? And the only reason don't worry about this one on the left, that's going right to the past. The only reason I put this up here was that you're thinking, well, why do cardiologists actually use these pressure volume loops? Yes, they do. And the end systolic pressure volume relaxation, right, which is described right here, these points right here, okay, right after ejection, are used to evaluate left ventricular contractility, and the changes here that we see in preload, okay, or the end diastolic pressure volume relationship, which is right here, okay, allows quantification of chamber stiffness. Okay, chamber stiffness. And they can even look at these pressure volume loops at different exercise intensities, for instance, and graph them up like this and determine how we're doing. Okay, so I was going to talk about the Frank-Starling law of the heart, probably an easier curve to understand. You've probably seen this before, where this describes the relationship between EDV, end diastolic volume, or preload, and stroke volume. Obviously, as EDV goes up, preload goes up, stroke volume goes up. We know that. Within limits, right? You're going to get a certain amount of blood in, and you can start to plateau. Okay? This, in terms of the stroke volume and the EDV, if you're in a hydrated state, let's say you're right here, so your EDV, you have an EDV here and a stroke volume right here. If you're in a dehydrated state, you sweat a lot or you're not drinking enough, your end diastolic volume is obviously going to go down because you haven't got as much blood returning to the heart. Let's say you've lost a lot of plasma volume, for instance, right? And of course, you're going to compromise your stroke volume. So if you're exercising or training in the heat or competing in the heat, that's why you want to obviously make sure you drink enough, right? Because if you don't, then you're going to compromise your stroke volume and then exercise performance. Very simple relationship between end diastolic volume, preload, and stroke volume. In terms of number 4, those changes in contractility, can that alter the Frank-Starling law of the curve of the heart? Yes, it can. Here's that control curve again, the red one. All right. If we remember, contractility is independent, or the force of contraction is independent of preload and afterload. We know that the sympathetics increase contractility, right? So what happens here? We move the curve up, that's all. If there's a decrease in contractility, we move the curve down. So if we increase force of contraction of the heart or contractility, we're going to increase stroke volume. If we decrease contractility or the force of contraction of the heart, the left ventricles, right ventricles, we're going to decrease stroke volume. The amount of blood is expelled from the heart will decrease. That makes sense? Okay. Let's talk about the vascular system. Briefly, you would have seen this before. Okay? We know it's made up of the arteries, arterioles, capillaries, venules, and veins. What's the difference between, for instance, the arteries and veins? Anatomically.
Arteries are oxygen rich.
Sorry, was that?
Arteries are oxygen rich and veins are oxygen depleted.
Well, they're not oxygen depleted,
Are
right?
they?
But you're right in some respects, okay? At rest, the veins have about 75% of oxygen still in them, right, at rest. But it is what we call less oxygen, okay? Anatomically, any difference between, say, the arteries and the veins? Arteries are bigger, might have a lot more smooth muscle. What else? We've already spoken about pressure and resistance changes between the two. Sorry, what's that? We're going to talk about gas exchange, obviously. That's not what I was really after in terms of, I was thinking more anatomically. Absolutely. Yeah. Anything else? So for blood to get down from the aorta down through the arteries and eventually to the capillaries where gas exchange is occurring, it's a high pressure system. It's a very, very high pressure system because it's coming from the heart. So that's all it needs. High pressure pulls the blood down through the arterioles, the aorta, arterioles, and capillaries. Fine. Gets to the capillaries, it's very sluggish. How about blood getting back from the capillaries, okay, back to the vena cava eventually, because we're going to go in this direction, capillaries, venal veins, vena cava, right? And then the heart. How on earth? We've got such a low pressure here, on how on earth is blood going to get back to the heart? It's okay coming in this direction, but we're pumping from the left ventricle. Very, very high pressure. You start getting down here, where you end up with hardly any pressure at all. You don't want it down there, right? Because the capillaries are very sluggish, that's where gas exchange is occurring. How's that blood going to get back efficiently to the heart? Venous return, we call it, right? Good. So they've got the muscle pump, the thoracic pump. By walking around, that's squeezing the veins, right? What's unique about the veins, though, compared to the arteries? What's the difference anatomically? Veins, if you recall, have one-way valves. Arteries don't. Right? So blood's squeezed in between the valves, and then it can't go back. And it's squeezed again, it's always milked, right? So that's important. So what we have here is this is a schematic of arteries, arterioles, capillaries, venules, and veins as a consequence of velocity, volume, diastolic pressure, blood pressure, and vascular resistance. As you can see, in terms of velocity, we lose velocity as we go from the arteries to the arterioles to the capillaries. That's fine. We want to do that, right? Because this is where gas exchange is occurring. We're at about 0.5 millimeters per second here. In terms of blood volume, most of the blood is pooling in the venules and veins because of those one-way valves. And mostly in the lower extremities, right? In the legs. So we call the venules and veins the capacious vessels of the body. Okay? Blood pressure is going to follow along with the velocity, okay? It's going to be high as it's coming out of the aorta, into the arteries, in the arterioles, down eventually to the capillaries and the venules and veins. It's going to get less. And then the resistance is highest in the arterioles. So those are what we call the resistance vessels of the body. Okay? Highly resistant. We can shut them, we can turn them off, turn them on, right? With those, what we call those sphincters. Okay? It's like a garden hose. So we can control blood flow very much so down the artery, down here in the the arterial level. Okay, blood pressure. You were saying again, you've seen something like this before. We know what systolic and diastolic blood pressure is. There's a few equations you need to become aware of. You'll know this one from the lab. If you've done the mean arterial blood pressure lab yet. Average pressure, mean arterial blood pressure, MAP, equals 2/3 diastolic blood pressure plus 1/3 systolic blood pressure. Okay, otherwise writing it. Or mean arterial blood pressure equals cardiac output times total peripheral resistance, TPR. So mean arterial blood pressure is dependent upon the cardiac output and the total peripheral resistance of the body. So of course, if the resistance of the total peripheral resistance goes up, mean arterial blood pressure is going to go up. Okay. General hemodynamics. We're going to talk about blood flow now. Okay? Blood flow. Now obviously, blood flows from a region within the vessel, high pressure to a region of low pressure. That makes sense. So there's a pressure gradient, high to low. That pressure gradient across the entire cardiovascular system is about 100 millimeters of mercury. Like I've spoken about before, the blood vessels and the blood itself provide resistance to blood flow. So I'm going to talk about this on the next slide. So what we have, for instance, we have a blood vessel with a certain length. We have a radius, of course. We have a pressure coming in, there's a pressure drop. That's inlet pressure, outlet pressure. We have a flow, a blood flow, obviously goes obviously in that direction. And the mu here is viscosity. Okay? And the viscosity of blood is really to do with how thick blood is, right? The more dehydrated you are, the higher the viscosity of the blood, the more sluggish it's going to be. The more hydrated you are, the better. Less viscosity. Okay? So there's all the factors that will influence that flow through a tube, because the blood vessels are a tube, right? Now, I've already said that MAP, or blood pressure, equals cardiac output, or blood flow, times TPR, total peripheral resistance. Also, another equation you may have seen before is cardiac output, Q, equals the change in pressure divided by resistance. Another equation, Sette's law, is blood flow, or flow through the pipe, equals the change in pressure times pi to the radius of that blood vessel raised to the fourth power divided by 8 mu, which again is that viscosity times the length. Now if you throw that equation into that equation, you won't be asked to do this in the exam, by the way, you're going to end up eventually with this guy here, which you will be asked to remember for the exam, which is blood flow is proportional to the radius of the blood vessel raised to the fourth power. Okay? Or as I've written down here, the resistance to flow through a blood vessel is inversely proportional to the radius raised to the fourth power. So, the question becomes, doubling the radius of the arterial 2 times, right? So on vasodilating, would increase the blood flow by how much? So doubling the radius, you tell me, of the arterial 2 times would increase the blood flow by there's your equation, right? 2 to the 4th, which is 16 times increase. So, the take-home message is small change in the radius results in a huge change in blood flow, which is exactly what's occurring when you exercise, right? You're vasodilating in the tissue bed. So a small change in the radius results in a very large change in blood flow because of this relationship. Blood flow is equal to the radius to the fourth power. Okay? And as you can see, that's what I've done here. Well, this is done pressure from another textbook. Double the radius, end up with 16 milliliters per minute. Make the radius 4 times bigger, you end up with 256 milliliters per minute. Okay? Okay. So how do we change blood flow? Well, blood flow is proportional to a change in pressure divided by resistance. Simple relationship. Okay? So it can change by either changing the pressure or resistance or a combination of both of those. We've already mentioned about changing resistance. Changing resistance has a larger effect on blood flow because it's force power. Okay? Vasoconstriction, vasodilation, you know those terms, right? Vasoconstriction obviously means the radius of the vessel is decreasing. Vasodilation is opening up. Important to remember, with blood vessels, they are only innervated by sympathetic nerve fibers. There's no parasympathetic nervous system innervation to blood vessels. So you're going to go, hang on a minute, I understand that if you increase sympathetic drive, you have more norepinephrine being released, blood vessels going to vasoconstrict. Right? How about vasodilation? You think, well, intuitively you think, well, that's where you need the parasympathetic nervous system, right? But no, there's no parasympathetic nervous system activity to the blood vessels. What happens is there's just less release of norepinephrine, and we get a vasodilation. So the blood vessels are under what we always call a sympathetic tone, a certain tone. If you increase sympathetic drive, the more norepinephrine is released, we get vasoconstriction. We get less norepinephrine, we get vasodilation. Okay. Factors then affecting the diameter of arterioles, there's many. But in terms of vasodilator agents, okay, making the blood vessel bigger, atrial natriuretic peptide, ANP, histamine, ones that we all know, nitric oxide is the big one, prostacyclins. There's no parasympathetics, remember. With vasoconstrictor agents, there's obviously norepinephrine. There's sympathetic drugs. There's vasopressin, angiotensin 2, we mentioned them before, endothelin 1. Are all vasoconstrictor agents can decrease the radius of the blood vessel. About that. In terms of then the intrinsic control of the blood flow, stimuli to increase the local blood flow. We're going to talk about metabolic factors. We're going to talk about endothelin release factors. We're going to end up with myogenic responses. Okay. All right. So, okay. You start to exercise. Down at tissue level, you're going to get a lot of unwanted byproducts. One of them you will know, lactic acid. You also know about protons. Okay? You're going to go into metabolic acidosis. You're going to have decreased pH. We spoke about that before. So those, I've just mentioned those. Increased oxygen, increased CO2, increased temperature of the muscle. Okay? What can happen is that those metabolic byproducts can work back onto the smooth muscle in the blood vessels and cause a vasodilation. If you cause a vasodilation, what's going to occur? You make that blood vessel bigger, then you get increased blood flow. Right? If you increase blood flow, those metabolic waste products are going to flush out the system from the tissue bed. So they work back on themselves. Okay? So this is a good thing. That's what we mean by metabolic regulation. Contracting muscle can also play a role. Myogenic contraction. Myogenic meaning muscle. Okay? A decrease in pressure causes dilation. An increase in pressure causes constriction. That's another way the tissue bed can regulate blood flow during exercise. Also, flow. Flow. If you increase the blood flow through the tissue bed, which is going to occur during exercise, with increased blood flow, okay? Outer lining of cells are the endothelial cells, right? Right behind the endothelial cells are all your smooth muscle cells. I'll just do one up here. These are smooth muscle cells. These are endothelial cells, okay? Increase the blood flow. These endothelial cells have these little receptors here, and they can pick up the change in the shear, what we call the shear stress. Shear stress caused by an increase in blood flow. In response to an increase in shear stress, because of this increase in blood flow, they will release nitric oxide. The nitric oxide can work back to the smooth muscle and relax them. Relaxing them, we get vasodilation. Okay? To accommodate this increase in blood flow. Alright? And that's exactly what happens during exercise. So the endothelial cells pick up the increased shear stress because the increased pressure, increased blood flow, release nitric oxide, works back onto the airways, onto the arm. The blood vessel, smooth muscle, relaxes them, and get vasodilation. That's what we mean by endothelium-mediated vasodilation. Okay? So 3 ways that blood flow can be controlled down at the tissue level. Extrinsic control, well, I've already mentioned that, the sympathetic nervous system to the blood vessels, not parasympathetic. Okay, integrated control of blood pressure. Blood pressure is maintained and controlled by the autonomic nervous system, it certainly is. Okay, we'll talk about certain receptors that can modify the blood pressure control through what we call cardiovascular control centers, located in the spinal cord, the upper spinal cord, actually in the brainstem. Okay. Baroreceptors, we spoke about those before, so these are stretch receptors located in the carotid arteries that are sensitive to change in blood pressure. We have chemoreceptors, these are, if you like, chemical receptors that relay information about the chemical environment, pH, CO2, O2, and mechanical receptors that sense changes in muscle length and tension. Okay. Okay. We're going to talk about the short-term regulation of blood pressure and the long-term regulation of blood pressure. So, here we have homeostasis, blood pressure in the normal range. What happens if that blood pressure goes out of the normal range? It certainly occurs during exercise. Okay? And then say it goes above. Arterial blood pressure rises above the normal range. What does the body do to bring it back down into the homeostatic range? Okay? Well, we have, like we said, we have baroreceptors, carotid sinuses, carotid arteries that are stimulated because of that increase in blood pressure. They will send signals, afferent signals, right, into the brain stem. And they either stimulate what we call the cardiorespiratory center or inhibit the vasomotor center. In essence, what's going to happen is the sympathetic impulses to the heart decline. Well, obviously that's going to be a decrease in heart rate, right? Really, the sympathetic nerve fiber is going to SA and AD node. Okay? And also, the impulse is going to the blood vessels. The rate of vasomotor impulses declines, allowing vasodilation. The amount of sympathetic drive is decreased. So peripheral resistance is going to be less because you've got the kind of vasodilation. So in essence, what you're going to have is a decrease in heart rate, which is going to lead to a decrease in cardiac output, a decrease in total peripheral resistance, right? Therefore, both of those will return the blood pressure to a homeostatic range. Because if you remember, mean arterial blood pressure equals cardiac output times total peripheral resistance. CO is just another way of writing cardiac output, right? I write it Q. Okay? So if you decrease Q or cardiac output, and you decrease total peripheral resistance, you can decrease mean arterial blood pressure. Make sense? Fairly simple, right? And I won't go through the declining one. The declining one is just the reverse of this. Increased cardiac output because of increased heart rate, increased sympathetic drive, and a vasoconstriction, increase in total peripheral resistance. Okay. So that's what's happening short term. What about long term? Long term control of blood pressure is a little bit different. So we have a decreased, it's very obviously slow acting, decreased arterial blood pressure. That's going to stimulate the baroreceptors. Okay. Sympathetic stimulation then from the baroreceptors in the brainstem promotes renin release. We all know about renin, right? Renin release is triggered from the kidney. It's a hormone. Renin can travel to the adrenal glands and produce angiotensin II. Okay? So it catalyzes the cascade resulting in the formation of angiotensin II. Angiotensin II is a very, very potent vasoconstrictor. So vasoconstriction, decreased diameter of the blood vessels. Angiotensin II can also cause aldosterone secretion by the adrenal cortex. We've been through this before, and therefore you're going to increase renal sodium and water reabsorption, right? And you're going to end up with an increased blood volume. So, if you've got a decreased arterial blood pressure, your body is trying to get it back to a homeostatic range. It does it by utilizing angiotensin II. Causes vasoconstriction. If you have vasoconstriction, you're going to increase resistance, total peripheral resistance. If you increase blood volume, you're going to increase blood pressure. Okay? And therefore you're going to end up with increased arterial blood pressure because of that. Okay? So that's long-term control. Don't worry about that slide. We've spoken about that. There's a few points. Last 1 minute on the functions of the blood important to exercise. Well, pretty obvious, right? In terms of the functions of the blood important to exercise: transportation, temperature regulation, acid-base, pH balance. What we mean by transportation is things like proteins, hormones, electrolytes, etc., etc. Obviously, very, very important. Composition of whole blood. So if I took you down to the lab and did a finger prick or did a finger puncture on you, which we do in lab a lot, not all that, but spin it down, we'll see something like this. Okay, we'll see all the red blood cells down at the bottom, we'll see the clear stuff at the top, And then what it doesn't show here is usually a white film between the two, termed the bucket coat, right? And the bucket coat is made up of, what is the bucket coat made up of, do you know? It's white, so kind of gives it away. White blood cells and platelets, okay? Obviously red blood cells here. The plasma made up of obviously water, proteins, electrolytes. We use the term hematocrit as well. Hematocrit is a percentage of red blood cells as a function of the whole blood volume. It's usually around about 45, or it's usually expressed as 45% or 0.45. Of course, if you dehydrate, you're out today and exercise for 2 hours and run, your plasma volume is going to go down. Your hematocrit is going to go up. The percentage of your red blood cells in our total blood volume has gone up, right? Your number has not gone up. It's just it's a percentage of the total blood volume. Okay, hematocrit. And that's what I mean there about hematocrit. And the last slide here on blood viscosity. Obviously, viscosity plays a big role in resistance. It does set up resistance to blood flow. Again, if you become dehydrated, you're going to increase the viscosity of the blood, therefore you're going to increase the thickness of the blood and the resistance. Okay? So the more viscous, the more resistance to flow. Higher hematocrits, of course, if you're becoming dehydrated, result in higher blood viscosity. We will talk about this all again when we talk about ergogenic aids. Some of these ergogenic aids that make your blood thicker. Okay, we'll come back to this, higher hematocrits and viscosity. That's a big problem. Okay. All right, that was a fairly long one. Let's take a 5-minute break, and then we will not finish off, obviously, the whole of respiratory. We're going to go to 9:50, that's okay.